Well, thank you everyone for coming today. We'll get started. A few others might straggle in, but we might as well get going. This is the first seminar series for NPSIA this year. I'm one of the co-coordinators. For those of you who don't know me, my name is Meredith Lilly, and I'm a professor here in the department. I am thrilled that we have 4 either Carleton professors or former affiliates with Carleton. Paul, have you taught in our department?
No.
Taught any NPSIA courses? No. Paul's in a different department, but all have relationships with international relations at NPSIA at Carleton, which is great. And I'm not going to spend a ton of time introducing them all because some of them are familiar to you. But we have Percieval, who's the lead author on this and is leading led the now completed Lancet Commission. I want to get the right title, Lancet Commission on Peaceful Society Through Health and Gender Equality, which is what she's going to talk to us about today. We also have Dane Rowlands, Timo Thoms. Dane is a professor in our department. Most of you will know him. If you don't, you'll get to know him most likely, especially if you take stats. And Timo taught stats for us, right?
And human rights.
And human rights. And Paul McKendawiri is an associate dean at the Faculty of Arts and Social Science and a professor here. So I'm thrilled that we have so many esteemed colleagues, and I'm going to put a plug in for the Lancet Commission because I know that the team is too modest to say so, but this is a really big deal. The Lancet Commission, Lancet is usually ranked in the top 3 medical journals in the world. Where is it ranked right now? It's top, yeah, number 1. And so being invited to participate in a commission and certainly to lead it is a very big deal. And it's a big deal for Carleton. And it's the reason that my co-coordinator and I decided that it would be great to profile our own, because we also as professors don't always talk about our own research in our classes. And so it's really good to be able to highlight for students at Carleton groundbreaking international research taking place by researchers. So with that, I will stop. Thank you all for being here. Team's going to talk for 45 minutes in total. Do you want to take any questions as you go, or you want to do the bit and then we'll have a discussion after? Maybe questions or clarification?
Yeah, clarification.
Clarification is okay, but then we'll have a broader discussion at the end. Thank you.
So I'll start. Thanks very much, Professor Lilly, and thanks so much for inviting us to give a presentation on the commission and its report. Just to emphasize the importance of Carleton in the broader commission, 10 of the authors were affiliated in some way with Carleton University. So Carleton made a big impact in terms of its research on this report. So today I wanted to go through about 4 things. The first is a context for the report, an overview of the objectives and the methods that we used, then review the report findings, and I'll share that with the Rowlands, and then implications for scholarship and policy, as well as next steps. And just in terms of the roles and responsibilities of all of us on this team, I led the overall management of the research and the report, the frameworks. I did some case studies. I helped interpret the quantitative data and case studies for the report, and the writing and revising. Timo and Dane, Professor Rowlands, really did, as you'll see, the incredible work in terms of statistical modeling, which was very, very complex and went well beyond what we had anticipated would be necessary at the beginning of this journey, and they're still helpful to me. And Professor McKendawiri provided really important support in terms of the framing of the report, integration of critical perspectives. You know, we and I'm happy to talk about this at the question and answer session. We did get some criticism during the report in terms of our lack of engagement with things like the colonization perspective, which was really important in helping us navigate that. So this is the context of our presentation. So for me, my personal interest in the relationships between health, gender, and conflict goes back really decades. Academically, health came up as a really important issue in early work that I did for my master's on environment and conflicts, the role of civil society organizations, and health just kept coming out. Professionally, I've worked in humanitarian contexts and also have done political analysis and advocacy. And for those of us who are working in conflict situations, you see the importance of health and gender firsthand, but there have really not been satisfactory frameworks that have enabled us to really understand their importance. And also I work on this in policy ownership. So when we were invited to participate in the Lancet Commission, it was launched in 2019, and we were tasked with understanding the interrelationships among 3 sustainable development goals. The one related to health, SDG 3, the one related to gender equality, SDG 5, and the one related to peace, which is SDG 16. So the genesis of the commission was really focused on the sustainable development agenda. We decided that we would go big in terms of our approach to this, and we examined a very specific question that is simple to state, but incredibly complicated to answer, and that is, can improved health equity and gender equality contribute to more peaceful societies, and if so, how? So while the world changed very significantly over the course of the commission's work, there was a pandemic, the conflict in Ukraine broke out, and now we have the conflict in Gaza, and the atrocities in Israel, along with many other things that are happening in the world. Our goals really did not change. So we wanted to bring together different disciplines to examine this question. So what we wanted it to be an interdisciplinary commission. We wanted to establish an empirical foundation that looked at the relationships among health equity, gender equality, and peace, and an empirical foundation that would speak to these multiple disciplines. We wanted also to contribute to national and global policy development by providing practical and actionable guidance and recommendations to these countries, as well as international organizations. So while we deliberately decided to undertake this broad and perhaps overly ambitious approach, we really wanted to establish this conceptual framework that started to help us understand how health, gender, and violence and peace related to each other. Great. Here we go. So in terms of the key terms that we used, I just thought it was important to define them before we move any further. So health equity means everyone, regardless of identity or socioeconomic circumstance, should enjoy universal access to healthcare services and essential medicines, vaccines, and technologies in a safe environment, respectful of individual autonomy, bodily integrity, dignity, and informed consent. Gender equality means that everyone, regardless of gender identity, can develop their human capabilities, access economic and broader public sector resources, live again in safety and security, and exercise agency. Sorry. So I wanted to just briefly review what the knowledge gaps were in the literature before, as we embarked on our commission. There really has been a failure to explore, while lots has been written on health, conflict, and gender and conflict. This research has really been characterized by a failure to explore the how and the why. So why these relationships exist and how these dynamics happen. So on interactions between health and conflicts, there's been clear and well-documented research that's assessed the impact of conflict on population health. There's also been some really interesting efforts to utilize health metrics as a tool to understand the dynamics of conflict, as well as, in transitional justice initiatives. There's been well-intentioned but empirically weak efforts to document the impact of infectious diseases and state fragility, as well as health interventions as a bridge to peace. On gender and conflict, there's been clear studies on how gender impacts on on how conflict impacts on gender equality. There's both positive and negative impacts related to this. So conflict has been an opportunity for expanded efforts to promote gender equality, but also the negative impacts associated with violence. There have been quite a few quantitative studies that link gender equality indicators to more peaceful societies. They're large M in scope and are very interesting, but they often lack the how and why analysis. So why do these relationships? So there's really a lack of frameworks to guide the inquiry amongst these relationships, and then there's a lack of theory to explain the association. So we're trying to fill that gap a little bit. So in terms of our research approach, our methods, we established first a conceptual framework that would help us chart out how these relationships existed. We then did an in-depth review of indicators, which I'll talk about just very, very briefly, to interrogate the what. Do associations exist? Timo and Dane undertook cross-national statistical analysis. And then to really understand the how and why these relationships exist and the implications for policy. We undertook case studies of both processes as well as case studies of countries. So in terms of the limitations of our research, this is really a first step. It's the beginning rather than the end. It's very exploratory in nature. We find both quantitative and qualitative approaches. These were really plausibility probes, not causal models. And we need definitely to start out our theory of change. And I think both in terms that further research should focus on case studies as well as implementation research. We faced pretty extensive limitations in terms of our data. And this made kind of intersectional approaches that our commissioners wanted us to undertake to be very, very difficult. And then just a note in terms of epistemology, the report definitely reflects the epistemology and the training of the researchers. We're all on the positivist side of the spectrum, and so the report definitely reflects that. I mentioned that we did an indicator analysis where we looked at specific indicators of gender equality, health, equity, and violence. And we did this in a very deliberative way. We had a template against which we assessed these indicators. These indicators are available on the Commission website. The analysis is available. So in terms of the insights from this, we noticed that there are clear gaps in terms of indicator availability. The focus does tend to be in the broader literature on the absence of data rather than the quality of data. There's little attention in terms of the transparency of the data that does exist, whether or not the data is measured or whether it's modeled, what assumptions are made when data is modeled, and confidence intervals are not provided, and yet policymakers will pull this data blindly without understanding these fundamental weaknesses. So just a quick note on that. It did take quite a while, so I think it's important for our research. To investigate our research question and really assess if health equity and gender equality have its independent role in the dynamics of conflict and peace was quite challenging. So we know that health and gender and conflict are shaped by broader social, economic, and political processes. Political scientists call this the problem of endogeneity. All of these processes interact with their broader context and with each other. So how do we even begin to conceive of these relationships? So to enable us to analyze this, we adopted the concept of self-reinforcing cycles, and we were really influenced and inspired by some work by Tabitha Suri, who is a development economist, who looked at the relationships between human development and economic growth and had this model of vicious and virtuous cycles. And so we were inspired by her approach, and we adopted it to look at the relationships amongst health, gender, and violence. So in a self-reinforcing cycle, which is basically what vicious or harmful cycles, virtuous or beneficial cycles are, a change in the value of one variable leads to a change in the value of others, and this prompts a cycle of further interactions within the system. So how we describe these cycles really depends on our interpretation of the outcome of that interaction. So health inequities, gender inequalities, and organized violence interact to reinforce each other with harmful cycles. Beneficial cycles are one in which health equity, gender equality, and peace reinforce each other. And in self-reinforcing cycles, a significant change in the value of one of the variables can prompt the dynamic of the cycle to shift. And so this is really where our theory of change comes in. So our theory of change is that health equity and gender equality improvements under the right conditions can help transform these self-reinforcing cycles, enabling societies to transition from harmful to beneficial. So that is outlined in this relationship. So you can see, we believe this was the kind of the conceptual framework and our theory of change that we tested throughout our work. So we also adopted, in terms of our framing, the idea of a polycrisis, which is quite in vogue right now, in order to kind of situate our research within the broader harmful cycles that we're seeing within society. And one of the arguments that we make in our report is that improvements in health equity and gender equality not only influence each other, but they can cascade across multiple systems within society. So one of the characteristics of polycrisis research is that it does tend to focus on the negative, and what we're trying to do is focus on the positive. So how can you change? So I will now turn it over to my colleagues to begin reviewing the report findings starting with statistical.
Thank you, Val. Before I start my remarks, I just want to say quickly, this commission started in 2018, 2019, worked over many years. It started with, I think, 25 commissioners. There are more than 30 authors on this report, but this report would not exist without Val. Like, she was the driving force behind it. And because there's so many people involved, I want to mention that. Okay, so I'll just introduce the cross-national statistical analysis briefly, turn it over to Dane. He will talk about some of our findings, and then he'll turn it back to me, and I'll talk a bit more about some other findings. As already mentioned by Val, the central research question of the commission was, how does variation in gender equality and health equity, so improvements or declines, influence variation in violence and conflict? So we explicitly adopted a notion of negative peace. We're not talking about a positive peace. So we pursued exploratory large N analysis to avoid false claims about the generalizability of relationships between gender equality, health equity, and peace, and to provide greater confidence in the external validity of the Commission's broader analysis. But these analyses do not examine the impacts of specific health and gender interventions, but rather begin to build an evidence base for broad statistical relationships between these three dimensions. Specifically, the aim was to explore if and how gender inequalities and health inequities and violence reinforce each other in these harmful cycles that Val mentioned, or if and how gender equality, health equity, and peace reinforce each other in beneficial cycles, and if and how efforts to support gender equality and health equity under the right conditions have the ability to nudge communities and societies from harmful to beneficial cycles. So these proposed cycles imply feedback loops in which health, gender, and violence variables interact with each other to produce mutually reinforcing patterns which can have harmful or beneficial outcomes. So our questions about cycles imply considerable complexity as they examine statistical effects between gender and health, so from gender to health, from health to gender, from gender and health outcomes to violence outcomes, and from violence to gender and health outcomes. So we're not just talking about reinforcing cycles between two variables, but between three sets of variables. And on each of these dimensions, we're looking at many different measures because there are many different ways of, that one can measure these things. So as depicted in this diagram, where the solid lines represent hypothesized associations within harmful and beneficial cycles, and the dotted lines represent our hypothesis about transitioning from harmful to beneficial cycles, that this is where gender and health can play an important role. So the key point here is that to take feedback loops and endogeneity seriously, we need to investigate our three sets of variables as both dependent and independent variables. So to briefly preview our overall analysis, I want to be clear on what we consider supporting evidence for our framework. So on harmful cycles, to support the existence of harmful cycles, statistical models would show associations between low gender and health indicators and high violence indicators. Countries that scored lower on gender and health performance would subsequently improve less than the global average and be more prone to organized violence. The reason why this is important is because overall, the time period that we look at is 1970 to 2015. Virtually every country in the world has improved on health and gender, but there are vast differences in how much they improve. Right? Countries with higher initial levels of violence would be associated with lower subsequent improvements in gender and health performances, or their gender and health performance might deteriorate. So that's on harmful cycles. And we find extensive support for this hypothesis that health inequity, gender inequality, and violence interact in these self-reinforcing cycles. On beneficial cycles, to support existence of beneficial cycles, statistical models would show associations among gender equality and health equity and peace measured by low violence indicators. So countries with high initial gender and health performance would maintain stable and high levels of subsequent gender and health performance. So this is really the flip side of the harmful cycles. So countries that initially scored higher on health and gender outcomes would be associated with less subsequent violence than those with poorer performance on health and gender indicators. And again, we find some support, not quite as much as on harmful cycles, and there are good reasons for that we're going to talk about, that health, equity, gender equality, and peace interact in self-reinforcing cycles with beneficial effects. But we also come to the conclusion that it is difficult to uncover such evidence due to what we call ceiling effects. And Dane is going to talk about that, and I'm going to briefly mention something about it as well later. And then to support our theory of change, statistical evidence would show that countries that initially score higher on health indicators would on average have greater subsequent improvements in gender and health outcomes to avoid future violence, right? Countries that initially score higher on gender indicators would have greater subsequent improvements in both gender and health outcomes and avoid future violence. And finally, health and gender would have interaction effects, where higher scores and combinations of gender and health indicators would show greater improvements in subsequent gender and health outcomes and avoid violence. I know that was a lot on one slide, but I just wanted to point out how many different ways you might show little parts of this overall framework that we're talking about. Okay, so while there are many other important factors influencing health, gender, and violence outcomes, I just want to be clear that we do not develop detailed causal models of each outcome, but we examine whether statistical associations between these outcomes are broadly consistent with harmful and beneficial cycles. So we see this as exploratory research as a first useful step in a larger research agenda exploring these relationships. And we employ both cross-sectional and panel models that Dane and I worked on together for quite a long time. Dane is going to present the cross-sectional models in a moment, and then I'll talk about the panel models. So the cross-sectional models allow us to examine long-term changes in the outcome variables over a 25-year period, while the panel models examine short-term variation from one 5-year period to the next, but over a longer time frame than the cross-sectional analysis. And the two approaches have different methodological trade-offs. While the cross-sectional models make it somewhat easier to address problems of endogeneity and scatasticity, They also have fewer degrees of freedom due to their smaller sample size, which is the number of countries included in the analysis. Panel models are subject to more concerns about endogeneity and heteroscedasticity and serial correlation due to the structure of the data used, which is several observations of countries over time. But they also have much larger sample sizes, allowing for more precision in statistical estimates. So we believe that both approaches in combination are valuable, and our panel models actually build on the cross-sectional models. Dane and I will talk a bit more about this in a moment. So, in terms of the data, we chose our measures guided by the indicator mapping that Val already discussed. That was carried out by the working group and a team of research assistants under Val's guidance, and based on our evaluation of the quality and coverage of these data. So it wasn't enough to be conceptually relevant for measures, but we also needed consistent data over time for a large number of countries. For the main analysis, we chose two representative and commonly accepted variables each for the health and gender dimensions. So for health, we used the life expectancy and the infant mortality rate. For gender, we used the mean years of schooling ratio of females to males and the age-specific fertility rate for adolescents. We also did supplementary analysis with other measures that are in this table, but those four are the key measures used in all of our analysis in some way. To measure violence, we chose several indicators to capture different types, including state-based internal conflict, state repression of physical integrity, so this is human rights violations committed by the state, and the total and civilian battle-related death rates per population resulting from varying types of conflict. And we drew on the Uppsala conflict database for all of our conflict data. Most of the analysis in the report focused on internal armed conflict. We did a lot of other analysis on other types of violence as well, but that's really what informed the report. And the last thing here is that all of our measures are aggregated to 5-year averages because several of our key health and gender measures come in this format from the World Population Prospects database. So we adopted that data structure for all of our analysis. We also use combined measures to decrease the number of combinations of variables in examining patterns of harmful and beneficial cycles, and thereby simplify, especially the panel analysis. We created combined health and gender indices. I'm not going to go into the details now. If there's questions, we can maybe talk about it later. And we developed a country classification system based on quintiles of combined health and gender measures in order to operationalize some interaction effects that I'll talk about later. And there's really two reasons for this. First is that simple correlations between two variables could imply that harmful and beneficial cycles are simply two sides of the same coin. But we wanted to allow for the possibility that they're not. This approach cannot distinguish between, so the simple correlational approach cannot distinguish between harmful and beneficial cycles and allow for the possibility that one could occur without the other, or perhaps more importantly, that they operate on different timelines, which is indeed something that we come up against in our analysis. And second, in the simple correlational approach, it is not possible to determine whether the gender, health, and violence variables actually mutually reinforce each other. So whether their combinations have statistical effects beyond their individual effects. And such effects can be investigated with interaction terms. But given how many different measures we look at, this can quickly become very complicated to implement and interpret, but we take a stab at it. So to make our analysis more tractable, particularly in the panel analysis, we opt for this approach using joint classifications, which is akin to including interaction terms. And with this introduction, I'm going to turn it over to Dane to discuss the cross-sectional analysis.
It's really good at statistical analysis.
But none of my students for one class are here, so they won't witness all the sins I've done. Okay, so the cross-sectional analysis, that you've got the sensitive data now, and one of the reasons we chose the data that we did was availability. So the smallest kind of samples we had were about 161, which is pretty good coverage given the number of countries in the world. As many as 180 in some of the analyses. So we've got pretty broad coverage, even in terms of the number of countries that report data. The dependent variables, so what we did, we had lots of different versions of this, but ultimately at the end, what we're reporting are just straightforward improvements in each measure over the period in the cross-section data from the 1990 to 1995 period to the 2010 2015. So this is the range that we're looking at. So this is quite a long time frame that we're looking at, and we're trying to explain this as simply as we can. The explanatory variables, so the regressions, there were lots of different regressions. I think Timo probably went through even an infinite number more than I did, but we basically tried a few approaches. One was to look at only the pre-19, so the 1990 to 1995 period initial measures of each of the dependent variables to see how much of that was able to explain subsequent performance. Then we added in economic, political, and other factors into the analysis. So these are, again, both pre and then post. And at the end, you can see that what we did was we combined the initial measures of these dependent variables along with contemporaneous changes. So one of the reasons we did this was if a country ended up, for example, in conflict in the post-1995 period, one would presume that this was going to have a severe effect on outcomes. I would say what we did was not structural equations. These were not embedded in theory and derived and all that. It was basically an exploration of associations. What shocked me was the remarkably high levels of explanatory power of the model. So in the case of infant mortality, for example, you could explain up to 85% of the variation in post-1995 performance with pre-1995 variables. And the lowest was in fact was still quite high. It was about 35% of the variation was explained for less specific fertility yields. So it was remarkable how much was explicable with just the pre-1995 variables, which suggests that there's a high degree of inertia in many of these variables. So just to go through this on the basis of the cycle theory, you can read what the effects are. We did find evidence that many of these variables are related to ultimate conflict. And in the harmful cycle side, at least in the cross-sectional analysis, almost all of the supporting evidence of this idea are related to the relationships of conflict. Okay, so either high levels of conflict emerge as a consequence of how they're performing in health and gender, or there will be a reverse effect or conflict associated with poor performance in some of the health and gender variable improvements. And I would also say on this two things. There's two broad effects I think are worth noting. One is that pre-1995 evidence of conflicts, or measures of conflict pre-1995, actually occasionally were associated with higher post-1995 improvements, which we attributed to as kind of like recovery. But then if you put the contemporaneous violence or conflict measures in, then you observe what we would expect, which is that performance on health and gender and other variables declines. So there is some kind of sensibility in terms of the relationship on the timing side. So that's as close as we got to endogeneity, endogeneity.
Sorry, so maybe you need to explain this at the end, but I just want to clarify or understand. Is it that the conflict, so you're saying that the evidence or the numbers show that it's not that the conflict leads to declines in health and equity. You're saying that it goes both ways?
No, I think if you had an early experience, if you had a the initial stage of the analysis, so the 1990-95 or prior, if you had conflict in that area, you often would observe recovery, so faster improvement. But if it was accompanied by contemporaneous conflict and violence, so that violence and conflict extended past the 1995 period, then you'd end up getting the reverse. You'd end up having worse performance. Right. Okay, and the final thing I would note just on this page is, again, there's a lot of nuanced effects that I didn't anticipate. So we had like three major measures of violence and conflict. So we had the incidence of conflict, as measured by UCDP, and then we had the one-sided violence death rates, and we had the internal conflict death rates. And actually, they didn't all perform the same way. In fact, it was kind of interesting to see the subtle differences that would emerge as a consequence of which particular form of violence. There's a lot more evidence of on the beneficial side, and this is just to emphasize one of the points that Timo raised. Strong evidence of ceiling effects, and we tried to deal with this in multiple ways. But at the end, we just basically said, look, if you're already performing really well, if your life expectancy is already like 92, you're not going to expect very much improvement, okay? Because there's a limit to how far you can improve, and that's true for all of these measures on the health and gender side. So there was this strong evidence of ceiling effects. There was secondary evidence that suggested it was purely a ceiling effect. So that if you looked at slices of the data, I had a student look at this for a lower income group, for example, and the ceiling effect disappears. So within a compressed range of income per capita, for example, you don't observe it. Okay. So it is, I think, a structure of the fact that you've got like extremely poor countries in this sample and extremely rich countries in this sample. There are a number of relationships, and again, this is kind of the interesting element that emerged at the beginning. Gender, some of the gender variables affected subsequent health improvements. Some of the health variables affected subsequent gender improvements. And so there was this kind of cross correlation that, again, wasn't necessarily anticipated at the beginning, but certainly is consistent with kinds of hypothesizing that Val and Timo talked about. At the bottom, there was a number of ones that were related to conflict. And again, in general, the results that we got suggested that worse performance initially on gender and health had implications for subsequent conflict being worse. And then, so you've got this kind of or 1990 1985 violence and health experience affecting what goes on, violence and conflict experience affecting what goes on later in health and gender, as well as the contemporaneous. And the final slide for me is this, on this transition question. A little bit of evidence here, a lot harder to do with the cross-sectional study. So more of this evidence of transition will emerge from Timo's panel analysis. But there was some stuff that looked at this. Yeah, this is I think consistent with the kind of hypotheses that we started off with in the analysis. So you can read those. I would only end up with two last points. First of all, we got a lot of really interesting, unexpected results in the analysis. So I would say if any students want to work on this, like there's like any number of tantalizing results that need to be teased out of these studies. A lot going on in here. So this is an enormous undertaking that Val launched.
Inflicted on you.
Yeah, but it was a lot of fun to see this kind of stuff. And again, this, as I said, there's like an infinite number of research essays that could be created out of this. So it's yeah. So I think I'll just leave it there. But it was really quite intriguing to see the analysis.
If you go back to the previous one, I just have a question about one specific point that missed. Yeah, that's fine. Sorry.
Okay. And we do actually have statistical tables for those who want to see that table. We'll do that later at the end. So Timo, you.
Thanks, Dane. Okay, so the panel analysis built on many initial findings from the cross-sectional analysis, but with data on a longer time frame. So this is from 1971 to 2015, again in 5-year periods averaged. And they systematically used interactions to explore conditional effects between the combined health and gender measures. So these are two-way interactions between these combined health and gender outcomes and conflict incidents. Again, these are two-way interactions. And between the classifications that I mentioned earlier and conflict incidents. And so these are three-way interactions. So using these classifications here lets us do two things. First, to examine whether particular configurations of health and gender outcomes, so the classification groups, are associated with improvement or worsening in gender, health, and violence variables. So here we would include models with binary or dummy variables indicating the group with one reference group left out to compare to. And so this can be interpreted as the effect of past health and gender configurations on current health and gender outcomes or on violence outcomes. And second, modeling interactions of these binary classification indicators with violence variables lets us calculate the statistical effect of past violence within each classification group on current health, gender, or violence outcomes. So this can be interpreted as a three-way cycle or interaction. We can test whether past violence in particular classification groups is associated with worse or better current health or gender outcomes or with more or less violence. The panel analysis were very extensive. In the interest of time, I will not go through many individual findings, but just summarize briefly the overall findings and maybe show you two brief illustrations of this. But there's a lot more in the appendix. On harmful cycles, so the panel analysis showed clear associations between low levels of country performance and gender and health indicators and organized violence. The low country classification, so these are the countries in which health and gender performance are in the bottom two quintiles on both indices combined, was associated with a higher incidence of future internal conflict than all the other classifications. The panel models also illustrated an association between previous internal conflict and decreased future health performance, especially again within the low classification group of countries based on health and gender performance. And the low country classification was associated with worse future health outcomes than all other classifications. Violence also had clear and problematic outcomes on gender equality. In the panel models, the low classification was associated with worse gender outcomes than some of the other classifications, not all the other classifications, but some. And conflict was associated with worse gender outcomes in all but the mid classification. So these are the countries in which health and gender performance fall into the middle quintile on both indices. And with the largest negative effect in the classification were countries that do not fit on the diagonal, basically between the two dimensions of the of gender and health, but on the off diagonal in which the country ranks in a higher quintile on gender performance than it does on health performance. That's how we define the off diagonals. So these results illustrate how conflict can reverse decades of progress in health and gender outcomes. On the beneficial cycles, some of our panel analysis specifically explore the issue of ceiling effect, which came up in the cross-sectional analysis, and we wanted to dig a bit deeper and make sure that that's really what's going on. And so we did this by examining conditional effects of past health and gender performance on each other in the current period, and we find very strong support for ceiling effects. And analysis of the panel data also illustrated that gender and health performance indicators were positively associated with peace. Higher levels of gender and health performance were associated with each other and with lower rates of internal conflict incidents and even of latent physical integrity repression, suggesting the operation of a beneficial cycle. So overall, we found evidence for both types of cycles, but much stronger on harmful cycles. So here's a good example of our panel analysis of cycles. This shows you the estimated interaction effects of past internal war on current internal war in the country, across the country classification groups. The outcome variable here is an annual binary measure averaged over a 5-year period. So that's why it ranges between 0 and 1. And here the past war incidents was associated with future war incidents in all but the highest classification group. So recidivism can happen across classification groups except in the highest classification group, which is the top 2 quintiles on both gender and health.
But just can you comment on the fact that on the relative position of the composition of gender equity larger than health? I mean, it's quite striking, the difference between these two, would be called off-diagonal.
Yeah, off-diagonal, yes.
Diagonal, yes.
Yeah, we don't have I don't think we have a good explanation for that. That's one of those things where we feel that it opens up new avenues for research. Generally speaking, we find a bit more consistent evidence on the health side than on the gender side. There's a lot that can be done on gender, and I'll get back to that in a moment with some other analysis that we did.
And then the mid, the fact that it's so high, I mean, suggests some kind of a reverse view.
Yeah, I mean, we see that really just in comparison to the highest classification. As you can tell from this, yes, we can distinguish statistically speaking between the two off-diagonal groups, but we can't really distinguish between the mid group and all the other lower classifications, at least in the models that we've done. So that's sort of one way in which these are really just exploratory analysis. Thank you. And so here's an example of supportive evidence for the transition from harmful to beneficial cycles. So we found clearer evidence, as I said, on the role of health and gender in this regard. This model examined the interaction effects of past health performance on, and past internal conflict on future conflict. So these are the same variables as before, but this time I'm looking at broader conflict, not just high intensity war. This shows the effect of past conflict incidents on current incidents across the entire range of the combined health measure with 95% confidence intervals. And so here, health performance conditions the association between past internal conflict or war incidents and subsequent incidents, right? As health performance increases, countries that previously had conflict or war are less likely to have future conflict. Note that while past conflict is always associated with future conflict, on average, this effect is much smaller at high levels of past health performance. So this is an interesting conditional effect. And it's important to note here that the confidence intervals at the very bottom of the range do not overlap with those at the very top, which really, to me, indicates that there is a statistical difference. So finally, we also conducted some simple bivariate analysis of sequences of health and gender change. For us here, the question was, are there particular sequences of improvements in gender and health performance that are more likely to break countries out of harmful cycles? To this end, we developed a simple sequence and typology based on combined and standardized health and gender measures, again, over the same time period. And this was a data-driven rather than theory-driven exercise. Considering the direction in the country's health and gender changes in each period in our data, we code whether combined health and gender measures improved jointly or whether one or both declined, which we label setbacks. And then we summarize the entire sequence over the 45-year period by aggregating contiguous periods with the same directions of changes, and determine whether any resulting segment is either health-led or gender-led, i.e. whether the standardized health or the standardized gender measure improves more than the other based on the slope. The goal of the typology was to categorize sequences such that similar pathways are grouped together. And again, this is really just exploratory. Given that all countries improve overall on both health and gender outcomes, setbacks sort of turned out to be useful distinguishing characteristic here. So in simple bivariate analysis of this sequencing typology, we find that different sequences are associated with varying long-term health, gender, and violence outcomes. And regarding the hypothesis about cycles, the analysis also supported, again, the association between poor country performance on health and gender indicators and increased levels of violence. So for instance, sequences involving health equity setbacks or both health equity and gender equality setbacks had the highest proportion of countries in conflict or war, including long-term conflict. So this would be 5 years or more. And countries experiencing health equity setbacks were associated with more violence as well as longer periods of violence compared with other sequences. Regarding the transition from harmful to beneficial cycles, these bivariate analysis suggests that health-led sequences were associated with more health improvements than gender-led sequences and sequences with health setbacks. So within these analysis, gender-led sequences do not result in great improvements in gender outcomes, which we found again particularly interesting because it indicates that gender has a much more complicated role there. And health-led sequences and those with health setbacks appear to be associated with more overall improvements in both health and gender outcomes than in gender-led sequences. But these differences are sometimes quite small. I think I'll leave it at that. We've subjected you to a lot of analysis.
You're beginning to understand why this took us 3 years, maybe. Just on the importance of health, one other piece of analysis that we did, which is in panel 19 of the report, is the relationship between official development assistance for health and conflict recidivism. And again, we found this really powerful role of health engagement and health assistance in reducing conflict recidivism across multiple settings. So I'm not going to spend very much time because we don't have much time left. I want to ensure that Paul has an occasion to speak. In the report, we have a section that looks at the how and the why. So we have the statistical evidence that supports these associations across time and space, although granted it's very complex. So in terms of the how and the why, we adopted Catherine Sinkink and Thomas Rees, a work on human rights and the integration of human rights norms within domestic contexts. We focused on how, so if you're looking at these relationships, it's not that improvements in health and improvements in gender automatically lead to peace. That's not what we're saying. What we're saying is it's the principles and mechanisms through which health equity improves and through which gender equality improves, which transforms capabilities. We applied the Amartya Sen and Martha Nussbaum capabilities framework, which in turn impacts on institutional structures, both formal and informal, individual agency, and this really amorphous element of power. So we spend a lot of time outlining what these principles are for health equity and gender equality, what the mechanisms are to actually improve health and gender, and why they result in this kind of catalytic or transformative effect. And we focus on the economic effects, lots of fantastic research that looks at the impact, particularly sexual and reproductive health on human capital and inclusive economic growth. Social effects, we did some really interesting work on women in peace processes, so the role of social capital in particular, bridging social capital and linking social capital. So we talked about epistemic communities. Political effects was harder, because political processes are much shorter in time. So it was harder to really develop this evidence, gather this evidence base, but we do have some evidence on the relationship between the provision of healthcare services and trust and the social contract. So we used some data from the SLRC Research Consortium that tracked trust in communities over time. And what we found, which was interesting, is that health improves trust at the community level. There doesn't seem to be a strong relationship with the state level, but that could be context dependent. Lots of really important and great research on gender and quality of governance, in particular, the relationship between gender equality and decreased corruption. So all of that can be found in the report. And again, putting it all together in our conceptual framework, you can see lots of feedback loops. So we have these harmful cycles, mechanisms and principles enable health equity and gender equality to improve, which ultimately can help transform harmful into beneficial cycles. So we're pretty clear-eyed about the dynamics of conflict and the causes of conflict, but we think that this is really interesting and important way to a framework for looking at these relationships. I'm going to skip this slide. One of the important things that we did is we looked at case studies of efforts to improve health equity and gender equality. In particular, Afghanistan, we had two wonderful students at NPSIA who were Afghan Canadian and who did terrific research on Afghanistan. And so one of the things that we talk about is to avoid the harmful cycles, we need to learn the missteps of the past. So we need to ensure that we do not instrumentalize health and gender for the foreign policy priorities of countries. We talk about the imitation projects, where this is where you take health systems or gender systems that work in one context and just supplant them in another and think that they'll take root and work. So, my work in Percieval was a clear example of this. Super heroine fallacy, we talk about how so much emphasis is placed on transplanting women into positions of power without really understanding the broad systems of gender equality that are the things that transform societies. So implications for scholarship and policy, again, I want to make sure that we have time for Paul, but in terms of what's new in this research, this conceptual framework is a new way of looking at these relationships. The role of health and gender, I think that we have enough evidence to suggest that health and gender does have this independent role in cycles of violence, and that was not something that existed before. We have a theory of change for how and why that happens, and we've established a research and policy agenda. So now I'm going to turn it over to Timo.
Hey, thank you, Bob. I think that I wrote this slide, and you can see it's different from the others. And I wrote it at 2 a.m. in the morning. But I think what I tried to distill from the mess that Timo and Dane and Bob kind of presented before us is what can we learn from a scholarly perspective going forward? And I came up with a couple of points, which are not exhaustive, but I think you cannot mix those from the report. And I know that as you read the report, you might come up with your own kind of things that do make sense and open up the lines of inquiry, or maybe, as Timo mentioned, the methodological section where there is issues that you might want to pursue further, but these are just things that I say maybe just to kickstart the debate. And I must apologize that I'm not going to stay past the next 5 minutes without having another meeting. So I'll run out straight. So from the lit review and from some of what we have this morning, what came out so strongly and so clearly is that if we're going to change gender norms around, health, I think we have to put communities themselves front and center, and that cannot just happen. Val talked about instrumentalization, or in other kinds of stuff. We talk about tokenism, we go into the community and just do things for the sake of doing it. But in this case, I think from a scholarly point of view, I think what it would require is that it would require a real paradigm shift in terms of how we live with communities, in terms of how we generate and produce knowledge, in terms of how that knowledge is mobilized and utilized by the community. Because each community, each setting is very specific, and we have to understand that for any interventions to be relevant and effective, it has to be informed by knowledge generated from those specific communities. And as scholars and as researchers, I think it challenges us. It challenges the power dynamic, the power relationship that we have with communities that we research with. And that is not just an epistemic shift. I think it also mirrors larger debates in research and debates about peace and international relations. To say that we need to understand the gendering and decolonizing impacts of many disciplines upon which we draw our reports, as we do research implement techniques, and that we produce knowledge. In other words, who leads the process of production of knowledge on peace, and how is that knowledge problematic from a colonial perspective, from a gender perspective, from an equity kind of social justice perspective. Dane and Timo spent quite a bit of time talking about the methodological and the methods, the techniques to look at, you know, the data that they use. And I think there's no question that they did a fantastic job, but it also begs a lot of questions in terms of what else can we bring that front to sort of tease out and clarify some of the blind spots and the gray areas that Timo mentioned. And I think that the conceptual framework that we used, I think, really challenges us to rethink the way we talk about these relationships, and from a conceptual point of view, but also from a methodological. I think one of the things that we might want to look at is look at things from a much more long-term perspective, understanding that both advantages and disadvantages can accumulate cross-sectionally, so across space, but also they can accumulate across time. And I think that's implied in the model itself. And if we conceptualize problems around gender, health, and peace along those lines, then it also begs for novel kinds of methodological approaches. Ones that probably can allow us to model social temporal sort of relations and patterns. Ones that allow us to model events, locations, and time. I'm a geographer, so that's why I'm saying that from that kind of perspective. And I think there's new, you know, advances in Markov chains of modeling that can help us. We normally use that when we model disease epidemics. How do these epidemics evolve in space? And I think we can use that kind of perspective to understand how accumulations of advantages or disadvantages across time can actually understand peace at a future time. We can apply those in a historical perspective as well. Another thing I want to point out is careful balance between the need for practical knowledge to inform. And I think Val, mentioned that in typical humanitarian settings, emphasis is on the practical needs, and much to the detriment. I'm not saying that that's a wrong thing, but in the process, we also miss all kinds of things. And one of the things is that we miss, or certain violations of human rights or gender inequities are kind of given a casual glance, and then and that is problematic. And I think as researchers and as scholars, we need to find the right balance between the need to generate practical knowledge to inform policy to address immediate humanitarian situations and needs on the one hand, but also engage in much more critical research that raises questions about the predominant views and predominant assumptions and models that shape and inform the policies that we use to respond to humanitarian situations. These are in no order, so if they don't make sense, it's because they're in no particular logical order. But the last one is more context-specific research on how health systems reflect and enforce gender and other impacts. This is very, very key. We tend to think about health systems as, you know, if you walk into a hospital, you feel like this is the most scientific place I've ever been, or, you know, everything is neutral, but no. I'm just giving an example of a hospital city, but you can talk about a larger health system. It's shaped by social norms of the society in which it exists, and I think we have to understand that health systems can be complicit in the production of inequities or inequalities. But if that fact is true, we can also argue that health systems can be used to advance the good cause of gender equality. And we know that, for example, healthcare workers are very powerful agents, and health systems are very important systems or systems in our society And everyone at any point, every other time, we were in contact with a particular system. I mean, so they are almost always present in our lives, and we can mobilize these systems to help us move the needle in the right direction. I think that would be a huge a huge resource for us. I think I'll stop there.
Yeah, I think we'll just leave it there. So if there's questions about kind of the next steps, thank you so much, Bob. Then we're happy to take that.
Not for me, I'm going.
We'll send you the question.
Thank you so
You're
much.
not on the
I appreciate it. Thanks.
Oh, thank you. Questions for the team? Thank you very much for that. Fantastic. Questions for the team? Any students have questions before we get to have to think about it. Okay.
Go ahead.
Okay, so I would like to know, and maybe you explained it and I didn't get it. Anyway, I would like to know, how do the indicator, because the title is all about health equity. And I want to know how the indicators that you chose distinguish between health, like just health indicators versus health equity indicators.
So that's an excellent question, and it's one that is difficult to necessarily answer. So one of the challenges with indicators availability across time and space is that the indicators that we have are not necessarily granular enough to measure equity. However, having said that, they're better than nothing, right? And they are indicative. The same is true in terms of gender equality. So these were questions that we have grappled with. How do we get at that kind of equity measure, intersectional analysis, and given both the limitations of data, of time, and of resources, we weren't necessarily able to do the kind of subnational, more survey, I guess, oriented studies that would enable us to get at those specific relationships. So that's definitely something that we talk about in the report. We look for proxies for health equity, proxies for gender equality, and much more work needs to be done to kind of get at the dynamics at the subnational level.
Okay, and so just one tiny thing further, you mentioned intersectionality. I want to clarify that your use of health equity doesn't imply only gender equity, right? Like
No,
all the other kinds of equity. Okay.
No, in the report, there's some various kind of case studies and analysis that try and take that approach. As you know, I think that having this conceptual framework, this empirical foundation, will enable future research to start to grapple with those kinds of, what elements of health equity are important. The other criticism that we got was that we didn't deal with the social determinants of health, which was far beyond the scope of, it was challenging enough to do this. So I think future research, particularly research that's case specific, community specific, could get at that kind of thing. Thank you.
I have a quick question off the indicator note. Research was done across a variety of countries. Was there a contextual, contextual overview of each country on what the baseline of their health system looked like, the health equity? Because for some bare minimum context, there's a lot of improvement possible, but in other ways, other countries might have less of a kind of like the ceiling effect, less of amount of improvement. So was that kind of also taken into account when looking at indicators and then vital health?
So the case study work that we did, are you asking specifically about the case study work?
Yes.
Yeah. So the case study work that we did it basically, it wasn't a proper mixed method approach. There were cases of what we call cases of convenience rather than a deliberative approach to case studies, given that this was an exploratory study. So they were cases in which members of the commission, well, basically members of the writing team had familiarity and had done research on before. So we looked broadly at health equity in Mozambique, or health equity, gender equality, and violence in Mozambique and in Afghanistan were the two broad case studies, and then we looked at specific processes in El Salvador, in Costa Rica, and Kenya. So those were the kind of the country case studies that we did. One of the things that I've talked about with Professor Rowlands is that I think a really interesting next step would be for both quantitative work on the indicators, including the ones that we outlined here at the national level. But with a more, given that we have this framework now, we have this understanding of how these factors sort of interrelate, start to really do much more in depth and hopefully it's supplemented with more qualitative and quantitative analysis at the subnational level. All of the case studies are available on the website and in the appendix.
Professor Dodeline.
Oh, I think we're out of time.
No, I was just first of all, well, Val, I think this is really interesting work. Three things. The first one, I feel really bad about asking that question. That you've done, but have you considered, I saw it in your control variables, you have you considered looking at horizontal inequality?
On what?
Horizontal inequality, the Sederman data set on which has proven to be a great predictor of conflict, much better than standard.
Yeah, we did consider it. There were sort of issues with getting data on enough countries over enough time. So that for this first cut, that was our primary determination, was to actually have enough for the entire period. Because we already were dealing with a lot of missing data issues with. So I think it's a great idea. And I know that the inequality data has improved a lot over the last couple of decades. So that's definitely a way, something to pursue.
Okay, my second question has to do with something that was mentioned. It's a high degree of inertia that was mentioned. So it also, I was looking at, see the question about your graph and medium being distinguishable. You talk about the ceiling. If was there a threshold effect? See, I'm thinking of the old work of Przeworski on GDP and democracy. At some point, I mean, if you're over it, then you're fine. Which let's say what's happening in the US suggests that Przeworski would just have been wrong. But at least in your field, do you see that?
That's really interesting. I think our analysis can't really pick up threshold effects because they're all linear models. I think you would have to specifically model to explore that. But it's possible, I think.
Yeah, I would always say, again, some of the stuff that Timo did especially, I mean, when the graphs, where we did the classification, we're imposing kind of an arbitrary threshold through the use of quintiles. But it is suggestive that, you know, you could probably play with where you did the cutoffs to figure out, you know, is there a point where the word threshold kicks in or not? But it is difficult to, you can probably do it easier in the panel because of the number of degrees of freedom that you have. But yeah, I think there's hints of this in the classification analysis, especially the keyword. But yeah, we didn't search for, you know, where we do a cutoff here.
Okay, and I have a last little one.
Please.
Regarding the transitions. Okay, is there a way to assess basically the extent to which one transition can be easier than the other?
That's interesting.
Yeah, especially thinking, we were talking about this morning about what's happening now in the Middle East. See, are the steps steeper one way, or see when you go up than when you go down?
Oh, it's much more difficult to go up than it is to
Yeah.
go down, right? It's much easier to go from beneficial cycle to a harmful cycle than from a harmful cycle to beneficial cycle, I would say. But I think an interesting question would be, is it easier, is it easier to go up through health if you're thinking about the transition and about what indicators you've improved to change the cycles? Is health an easier entry point than gender? And I think, when I was at the Wilson Center, I was doing stuff on gender backlash, and I think that would be really interesting to explore.
Yeah, the results on just the stronger effect of health suggest that, let's say, the efficiency of health intervention may be higher.
The efficiency of health interventions, but then health is also deeply reversible, right? So one thing that gender equality isn't as reversible as health equity. But that's really.
So can I just clarify the last point? Val, when you're talking about gender backlash, is the idea that an easier into these issues is health equity and health issues because it's kind of less political and bit cloak and dagger in a way? Is that the suggestion?
A little bit. I think one of the things that is interesting on the gender side, and it gets to the missteps of the past, right? Is how gender equality is portrayed and is characterized within societies in which they're embarking on that journey. We're all embarking on that journey, but I think that particularly the research obviously in Afghanistan shows how challenging it can be if that is not driven and led from internal actors, and how very, very well-meaning things like feminist foreign policy can really be problematic in terms of how that's portrayed, how gender equality is portrayed. So it's not, if you think what we focused on in our report was mechanisms of gender equality, so school, access to infrastructure, access to credit, very, very basic things. And I think a focus on that is much more neutral ground than, the kind of let's fund, even though we talk about the importance of advocacy networks, the focus on feminist advocacy networks puts a really problematic shadow over a lot of these organizations.
Just one thing that one of the interesting results of Listen would have liked to explore it further, but in some cases there was evidence that conflict was actually associated with an improvement when the gender really worked with quite the education, the ratio of education came up. And we looked at that, we thought about it, and this is a question of, are we getting appropriate indicators? Because that measure, one of the explanations that we came up with was the idea that, look, if you got conflict, it's the boys who are leaving school between the armed militias. And so what you observe is an improvement in the ratio, because the boys' attainment goes down, the girls' attainment go up at school, but that's not really the kind of effect that you want to observe in this case. So there needs to be a little bit more granularity in terms of some of these measures, but they're difficult to find. So
and just on that, I think one of the big knowledge gaps that we talked about, and we had a few papers that looked at this. So I had one student that did a review of humanitarian approaches to sexual violence against men. Just the absence of focus on masculinity, men, in terms of the gender analysis cohort for women. And I think, there's some really interesting work done in the United States by Richard Reeves at Brookings.
Yes, he's very good.
He's fantastic, and he's very non-ideological. It's just data driven. And I think that that's the kind of thing that we need. And, if you look at one of the groups that is really left behind in many of these in interventions and peace building and humanitarian is adolescent boys, right? Anybody that's worked in humanitarian context can tell you that, so.
On Richard Reed, he was one of Tony Blair's advisors, and I got to know him through his work on income inequality. So he's been working in other issues, and then he moved into boys and men for a particular set of reasons, but his work has attracted a lot of attention. It's quite good. Any other questions? I will wrap things because I know this room at 1 o'clock is booked for something else, but I'd like to thank you all for being so generous with your time. This represents an enormous amount of work, and you were only able to touch on kind of some of the top level points today. I encourage everyone to read the report. It's up on the Lancet website and is easily found there. So please join me in thanking